computer. And
when we were a motorized bicycle company, they said, you'll never be more than that.
Wow.
What will they say next? Honda, the power of dreams.
Not sure why we got a Honda commercial in the background there. Okay. Boy, I sure am rusty. Hi, everybody. Let's try it again here. We are going to be talking about the 5 dimensions of tongue tie today, and it's going to be a little bit longer than an hour. I'm going to try to keep it to an hour, so I hope everything works out with that. We've got a couple of people still joining in here, so I'm going to be kind of jumping a little bit to make sure that I can get people in. Please keep yourself muted, and hello to everybody who said hi to me when I was trying to figure out why I was having all this extra noise. My name is Shirley Gutkowski, as many of you know, and I am the owner of Primal Air, where we offer services to patients for orofacial myofunctional therapy, and we educate, as we are in this webinar. We do office training so that offices can understand better what it is that they're seeing and how to refer patients for myofunctional therapy or orthodontics or just a mandibular advancement device. And we also do mentorship here for new myofunctional therapists who are afraid of getting started. There are so many hygienists that have taken the classes for myofunctional therapy and don't know how to get started. So we help them with that too. We have a lot of people in here. We have one of my proteges here, Angela Masana, is here in New York. We have a few people from New York. You guys stay up late. So that's been pretty fun. So let's just continue on here. This is what we consider common with these little tiny teeth, and they're all jammed up together in a 3-year-old. This is another example of what we consider to be common, but it's not normal. So it took me a while to find this, but I did find a person who has a 3-year-old with spaces between their teeth. Now, Dr. Boyd tells us that we should have enough room to fit a dime between everybody's teeth, between all of the teeth at this stage. So I found it very difficult to find a person like that. And this happens to be a patient of mine's granddaughter. She's been breastfeeding and nursing for her whole time. So this is exactly what it is that we're looking for, and we don't find it very often. Oh, get carried away here. So that's what we're going to be talking about today. What is a tongue tie? Why should we care? And does a tongue tie really affect the teeth? And how much does it affect the teeth? And what compensations are there to accommodate oral function in our patients? There we go. There's 2 people here. Isn't it all? So in a nutshell, this is what we see. We have compensations here. We have compensations in the neck and the shoulders. We do measurements to make sure that the tongue isn't tied. It's not just, can you stick your tongue out? This is how the tongue is supposed to be. It's supposed to be resting inside the palate, and it's holding up the palate, if you will. This is poor oral posture. I don't remember learning that term in my hygiene school, but I did take classes. We had at least one unit on myofunctional therapy, and it was really captivating to me. But I never did anything about it because you get out of school and right away, you can't do half the things that you learned how to do. So this is a picture from the side, and you can see that the tongue is holding up the palate all the way to the soft palate. All the way to the soft palate. Hold on, somebody has their microphone open. And that is what we want to see, but too often this is what we see where there's no attachment here between the tongue and the palate. And we've known that there were problems with oral breathing for a long time. And if you graduated kind of in the 1980s, like I did, we were taught to find patients that were oral breathing by looking at their anterior gingiva. And then we would say, oh, do you breathe with your mouth open? And then we were supposed to say, you should stop that. You should breathe only through your nose. And these are a couple of studies to show why that's so important. Oral breathing jacks up the jaw joint. And we've known about this for quite some time. If you just think about it, when your mouth is open, the jaw joint is in the wrong position. So you really need to make sure that your patients are breathing through their nose. Intermittent hypoxia cannot significantly change the overall structure in the cause of short-term hypoxia stimulation, but the intermittent nasal obstruction can alter the condyle. So all of that kind of starts with the shape of the face and head as the baby grows. We have to use the term craniofacial respiratory complex to really hone in on what it is that we're talking about. The brain grows the top of the head. The mandible grows because the midface grows, and the midface grows due to tongue position. Dentistry oversees the growth and development of the craniofacial respiratory complex. And I would dare to ask anybody who else would be in charge of that. If we don't include the respiratory complex in this whole discussion, we have an inferior grasp on what it is that we're really doing. And it really forces us to see tiny babies because we are in charge of that whole thing. If their nostrils are blocked, if they're breathing through their nose, if they're breathing through their mouth, they are going to mess up their teeth. And the whole system kind of falls apart. I know it's super cute when a baby is snoring. When my kids were little, actually, I don't even remember if they were breathing noisily or not. But today, with grandchildren, I was very relieved to hear them breathing because then you know they're alive. And it's hard to kind of get back into that and think to yourself, okay, no, they're not supposed to be making a sound when they're breathing. Breathing should be silent all the time. So we have a lot of problems that accumulate over time when we don't do nasal breathing. This study here demonstrated a rotation and in the mandible, increased overjet, mandible plane angle, higher palatal plane, and narrowing of both upper and lower arches at the level of the canines and first molars compared to the nasal breathing group. 49% of mouth breathers have posterior crossbite. They have an increased overjet. They have a higher tendency for clockwise rotation of the growing mandible and disproportionate increase in the anterior lower vertical face height and decreased posterior face height. all of that sounds pretty scary when you get right down to it. This study was published in 2015, Dental Facial Characteristics of Oral Breathers in Different Stages. And they found that particularly for class 2, the oral breathers, there were more oral breathers in the class 2, angle class 2 category than nasal breathers. And in the class 1, there were more nasal breathers than oral breathers. We also know that oral breathing lowers the oral pH. With lower pH in the oral cavity, we have a situation where everything is an appropriate growing medium for pathogenic bacteria and a poor growing medium for commensal bacteria, the bacteria that live healthfully and happily in the mouth, that belong there. Once you start decreasing the oral pH, you start having this downward spiral of bacteria. And when we're talking about little kids this size, then what are you going to do when they have cavities, right? You're always putting fluoride on the teeth, which doesn't do anything really if the oral pH is always low. So discovering that they are oral breathing and then doing something about that besides saying breathe through your nose is really imperative. Dr. Michael Gelb talks about teeth as the reason for teeth is to hold the airway open. That's where he's gotten to. So when we look at this caries imbalance diagram that we were handed down from the California Dental Association and the Canberra group, we see that there are disease indicators and risk factors and protective factors. They have yet to come to grips with looking at whether or not the tongue or the whole oral architecture is cariogenic or protective. We know now in the myofunctional therapy realm that a tongue tie or a low labial frenum attachment can be considered a risk factor for caries, and that a freely moving tongue, a wide arch, and high labial frena are protective factors. But in dentistry, we have a very low tolerance for tongue tie. This is obviously a tongue tie, right? It's pretty obvious, but look at this kid is pretty old. They already have permanent teeth in the front here. They already have a stainless steel crown. They've obviously been to see the dentist before. Why hasn't this been resolved? Why is this kid already old enough for anterior permanent teeth and looks like at least 6-year molars are back there? How did this kid get this old and never have that tongue tie released? And why should we? This is part of the reason why. So this is a MRI, and that I stopped the MRI at a certain location that showed this part of the oral cavity. You can see that the anterior portion of the tongue is against the rugae. I know, rugae. How do you spell that? I don't know. I have to respell it every time, and I never thought I'd have to say that word again after hygiene school, but here we are. The tongue is up here, but it is only not even the anterior 1/4 of the tongue that is up against the maxilla. The rest of it is slumped down. And when you follow the air in through the nose where it belongs, and then follow it down through the oropharynx, we see how narrow everything gets right here. We can see too that the epiglottis looks as though it's touching the back wall of the airway. So breathing, whether or not this person thinks they're breathing okay, is a little bit tricky because air is skinny, right? It can go into terribly small places, but this is a hindrance. Mouth breathing is what happens. So if you look here and you consider how squeezy this is right here, you can imagine that this person is probably breathing with their mouth open just to give more space in the airway. And when you have a restriction that disallows the tongue to move around, you end up with a variety of dental malocclusions. This is the array. Depending on where the tongue is going to accommodate whatever restriction there is, everything from the nose all the way down to the lingual frenum, is how you get all of these different kind of malocclusions. This was shown in a study here, how the short lingual frenum is associated with obstructive sleep apnea at later age, and a systematic screening for the syndrome should be conducted when this anatomical abnormality is recognized. This is by Dr. Christian Guilleminault as the lead author on that, from looks like 2016, so it's a little bit ago. And it's creeping into the literature and into the psyche of many dentists. The first thing we kind of look at is the Kotlow free tongue length measurement. That is 0. We want from the tip of the tongue to where the tongue is attached to the underside of the tongue, we want that to be 16 millimeters or more. And when it's less than 16 millimeters, we end up with kids with obstructive sleep apnea. And look at these kids. What is happening where you have giraffe CPAP machines, where you have kids on CPAP machines and headgear? So this is headgear that pulls everything forward because the masks on these CPAP machines are pressing against the maxilla even more. So we don't know that these children have tongue ties that needed to be released or that they had some other kind of myofunctional disorders, but certainly this is an eyebrow raiser. We need to get to these kids early so that we can keep them from developing these poor sleep habits and this poor sleep architecture for when they're sleeping and their tongue is in the wrong place. This study here was a frenectomy study that showed there was 89% speech improvement. And, you know, some of us are like, okay, who cares? Solid feeding improved, 83%. Okay, well, they can always just gain weight. 83% improved sleep as reported by parents, and the parents should quit their job and just deal with a sleepy child. And 50% of speech delayed children said new words after the procedure. Oh, really? What is the big deal of that? 76% of slow eaters ate more rapidly, and 72% of restless sleepers slept less restlessly. Now you put all of that together and we've got a big story. And this is just one study, and it was 300, it was under 400 kids, but over 300, somewhere in between there. I don't remember exactly right now, but this is a massive improvement. And okay, let's say it's only half this good in reality when you start adding boatloads of patients into it. It's still a pretty big improvement. Solid feeding improved. That's really huge. Sleep improved. Do you know that there's no way to tell between ADHD and sleep deprivation? That's how many kids are on this train. How many kids do you see in your practice who are taking ADHD medication and really they could be just sleep deprived? When you're sleep deprived and you're in second grade, the most important thing that you don't want to do besides calling your teacher mommy, that's a no-no for sure. The next thing is to fall asleep in class. So they look for little opportunities to get an adrenaline hit. They squeak the chair, they talk back, they pinch their neighbor, all of that kind of stuff, and that's what gets them in trouble. Tongue ties also lead to poor arch development. This one is very, very narrow anteriorly. You can see the teeth are overlapped right here. This is the lower arch. We've got all the teeth kind of in a weird arrangement here, a little bit of crowding. And we have these attachments that are unobserved. When's the last time you ask your patient to lift the tip of their tongue behind their upper front teeth? And if you did that, would you notice that there is a blanching right here? And why should you care? This blanching still travels right here, but it's not quite as bad. And you would never say that this person has a tongue tie. And then when you see this right here, this attachment is where the mystery tongue tie comes from. We want this Wharton's duct carbuncle to be on the floor of the mouth. It should never be raised. It's raised right here. But this attachment that's supposed to be at the level of the premolar is on the mandible. This allows the tongue to come out. It's got a long blade, but the attachment is way forward here. That's why it's blanching under this position. And then this idea of bruxing and tori growth, we were told that bruxing does not cause tori to grow. Look where this attachment is. This attachment here is on the mandible, or was, and due to constant use, we see more and more bone deposition. This is where the tongue is supposed to be attached. If it can't reach here, there are a number of problems that occur. One is that the upper arch doesn't develop totally. Two is that there's a neurology here. There's an open circuit between the tongue and the palate, which I can't describe very well. But there is a neurology here that has to occur. If we have this open circuit here, there's a thread right now of researchers wondering if that's maybe where the torus is coming from, where there's bone deposition up here on the palate that's trying to reach the tongue. So that's a pretty cool way of looking at it. There's a huge nerve supply, a diverse nerve supply that goes to the tongue. All of these ones that we had to learn that we never ever used again. It's a real struggle to remember all of these now. But these nerves need to be touching against the greater palatine, which is the major nerve that innervates the palate. And you can see here, this is a pretty sick person. This is the maxillary torus right here. It has not yet reached the tongue. Look at this airway. This is a cramped, I'm calling this a cramped epiglottis. The ENTs are saying it's normal, and I'm trying to go along with it, but I only see this in symptomatic patients. And if they're not looking for tongue tie and they're not obsessing airway, they're calling that, normal. They're not seeing this thing either. What you don't see is just amazing. So we've got the front of the tongue is not even really against the palate. Maybe it is because this box is in that one spot. But look right here. Look how much of the ventral surface of the tongue is being pulled down by this frenum. If you counted her teeth, you would find out she has 4 premolars missing. This tongue was never addressed, the teeth were pulled, and everything slumped backwards. The Orthodontic Society will argue with that, and I'm not going to say anything more about it other than to say, think about it. And here is the second view of that x-ray that I showed you a little bit ago, where the tongue was not against the roof of the mouth and it was slumped into the airway. This person was born in 1947, so she's been, or I think it's a she, it says F. She's been living a long time with this misery. This is where anxiety lives, because your body is afraid that you're going to collapse during the paralytic sleep stage. And 20 minutes after the release, and this person did have myofunctional therapy, so the tongue knew where to go, look at what happened to the airway. It's really amazing. And this little part right here can be part of the mystery for us as we're observing our patients. This is my own granddaughter. It took me 3 years to find that. She never ever held her tongue in the correct posture for me to see the attachment. So believe me, I look now. I look for this attachment. And it is on the mandible, and she did have to have her tongue tie released. Now, nasal breathing is almost impossible for some people with a deviated septum. And I'm going to show you now where the idiopathic deviated septum may be coming from, because we hear that quite often. An idiopathic deviated septum means that nobody knows why it's crooked. They didn't have an accident, they didn't get hit in the face with a ball, they didn't fall off their bike, blah, blah, and nothing happened. But look at this is exactly the right scenario for what it is that we're trying to describe. This septum is obviously crooked. And when you see where the tongue is resting, you can see that the tongue is resting low. And what happened here is that the top of the head grew because there was brain development, and the mandible grew following the maxilla, and the maxilla grew disproportionately to the top of the head. So you had a mismatch of growth. The tongue is supposed to press up against the maxilla and press it wide and low. This woman is 70 years old and in misery also. She wants to breathe better. She wants to live a better life, and she cannot afford to have her arch developed now because that's pretty expensive. You can develop an arch in an adult, even a 70-year-old adult. We're watching it happen every day now. And because of the way that the fascia is, we see that the fascia on a person with tongue tie may be contributing to idiopathic scoliosis, where the shoulders are uneven. And not only is there a curve in the spine, like if you're looking from the side of an S curve, it curves left to right instead of front to back, or also front to back. This is the fascia. It's kind of knots up here. I like to describe it like it knots up here under the tongue, and then it just encompasses almost every single muscle all the way down the front here and gets the feet involved. The people that are on videos on the Breathe Institute the Breathe Institute YouTube channel are very excited to talk about all kinds of body reactions that they have. Some of the earlier videos are of people talking about their feet lining up better, and that's not falling off to the side anymore. There's one really good one of maybe I think I even have it here. Nope. A really good one of a dancer who right after her release was talking about how many more muscles she could control even while she was still in the chair. Now, this does not come from a one quick little zip with a laser. This is a functional frenuloplasty. If you're going to go in with a laser and just break that frenum, you're not going to get those kind of results. The functional frenuloplasty means you go into the tongue between the muscles and you separate all of the muscles and you find the little marionette fibers that are holding the top and the bottom of the tongue together, and you're breaking those fibers as well. It's the most unusual thing that I think I've ever seen. It's really bizarre. So what can you do yourself? Well, you can look at the health history for one, for your, especially your older, like teenagers and up patients. Are they on high blood pressure medications? Are they taking medications for ADHD or GERD or restless leg or headaches? Do they wake up more than once a night to go to the bathroom? You're going to look in the mouth. Do they have a tongue tie? Do they have enlarged tonsils, which is an indication that they're oral breathing? Dry lips, oral breathing. Let's remember that the lips have no oil glands, so they need to stay together in order to not dry out. Just a basic dry mouth, even an enlarged uvula. So we're going to go through two different categories here of what to look for. And we're going to go through, this is the children's one, and then we're also going to look at how to do an assessment on adults. So this is the Chicago Hearts acronym by Dr. Kevin Boyd, who is a dentist in Chicago, and he has been doing a lot of research on an archaeological kind of research where he's looking at skulls from antiquity and measuring and evaluating what the skulls were in infants and children back then as compared to now. And he's been making some real eye-raising or eyebrow-raising findings. So the first is the C in Chicago Hearts, and that would be a crossbite. So we don't call this class 3 anymore. We call this an anterior crossbite. We also have posterior crossbites. If the tongue isn't holding everything in alignment, then crossbites are us. Crossbites come up. Then the H in Chicago is hyperdivergent facial patterns. This long, narrow face, especially common in people that have orofacial myofunctional disorders. And we see this weird kind of mandible that I'm still trying to figure out what it is I'm even looking at. I mean, it's just so long. It's at such a bad angle. We're looking at hypertrophic tonsils and adenoids. This is not okay. When tonsils are this big for too long, then we have a different tissue that is forming here. So they have to be removed. They cannot just shrink. So you want to get them as soon as possible to get them to shrink. Incompetent lips. That's where the lips won't close for whatever reason. Constricted arches that don't allow for all of the permanent teeth, or these little 3-year-olds and 4-year-olds that we started this presentation with who have no space between their baby teeth. That's a cardinal sign. You're going to look at airway anatomy. Don't wait until they're 17 before you do a CT scan to look. I mean, you can have a pretty good idea of what's going on with their airway with just looking, but if you suspect anything, it should be done right away. Tooth grinding. No child should be grinding their teeth. This is completely tied to an airway and breathing disorder. It is not a stress. It is just them trying to move their tongue out of their airway. Kids who are overweight are very often also sleep apneic first before they got overweight. So it's this first kid here who's suffering from some kind of a disorder for breathing and sleeping, and then that jacks up the hormones and makes them want to eat. We want to see no kids with a high vaulted palate. This is not always due to thumb sucking. Thumb sucking may be the child's attempt to close that circuit between the tongue and the palate. It also helps to hold the tongue down a little bit and out of the airway. All of the skulls that Dr. Boyd is finding all have wide, narrow arches until the industrial age. Here we go. Here he is, pre-industrial and modern day. Kids with eczema on the face. I would call this windburn if it was Wisconsin and it was February, but if it's eczema, it's there in the summer. And that's a breathing disorder. The current conversations that I've been part of with respect to eczema is that because the oxygenation is so poor, there isn't good oxygenation that gets to the surface through the capillaries. There's not enough oxygen. Once we get the mouth closed and once they start nasal breathing, the eczema kind of goes away. Scleral showing, scleral or venous pooling under the eyes. These are also signs of disturbed breathing patterns. Anterior open bite, not only from the thumb, not only from a blanket, not only from eating their shirt, it's because their tongue is not working correctly. It's pushing forward. And look at the blanching of this, this frenum here. Retrognathia. Is it true retrognathia or is it the maxilla that's wrong? Tongue posture. I have a patient that has this right here, right now. And I'm like, holy moly, how does that even happen? How does she get to be past 12 with her tongue so low? And look what happens to the palate. When the tongue is in the right place, everything else is in the right place. When you see scalloping in a child, that's a really red flag. This is a very classic tongue tie. Look at this kid already has braces and nobody ever even looked at the tie. Septal defects is also common in these people that have restrictions and abnormal breathing patterns, even in children. We used to call this the throat, and now we have to call it the airway. Calling it the throat does nothing to help you understand what is it going on. We have to see black back here. We have to see behind the uvula. We have scoring systems that help us describe what it is that we're seeing. When I first learned about this, I thought that all the class 4 people were going to be in the hospital and just ready to die. I thought this would never walk into my room. They walk in all the time, all ages. It's crazy. So what are you going to do for your chair side observations? And so what I used to say was, that's weird. And then that was it. I've never seen anybody writing it up. I've never seen comments about, well, maybe large tonsils, but certainly not an enlarged uvula. This right here is a ventral funnel where the frenum is pulling down the ventral side of the tongue. I would never mark that down anywhere. Now you have to, because now you know the scales have fallen from your eyes. So now you have an adult in your chair, and now you're going to do your basic oral cancer screening. And you're going to go, that's weird now. And now you're going to write it down because now it's going to mean something. When you see sharp rugae, I don't even know if that's spelled right. If you see a narrow arch or a wide alveolar ridge, those are things to mark down. Those are indications of a restriction in the tongue. If you see a visible uvula, that's good. You're going to look at the tonsil size. You're going to give them an airway score using the Mallampati score, which is the tongue out, or the Friedman, which is the tongue in. Whichever one you use, just keep using the same one so that you don't get mixed up. You're going to note the attachment location of the frenum onto the tongue. You're going to note the length. You're going to note the floor of the mouth attachment. Are you going to write it down if it's perfect? No, you're only going to write it down if it's forward. It's never not going to be forward later. So writing it down once is just a cue to you next time that you have to start asking more about breathing and airway. You're going to notice a divot in the dorsum of the tongue. You're going to make sure that the tongue can extend. You're going to look for scalloping of the tongue, and you're going to mark all that down in your chart. If there isn't any, then you're not going to do any. But you're not going to just go, that's weird, and call it a day. You're going to note whether these labial or buccal frena are tight. You're already looking, right? You're doing a cancer screening. If it's too low down here, if it's near the teeth, if it's too tight, if it blanches easily. Is it dry up in here, up in the vestibule? Is the frenum inflexible? Is the gag reflex overly triggered? You're going to look for cheek biting. You're going to look for scars, also flexibility in the cheeks. Same thing on the lower. You're going to look for tightness of the labial and buccal frena. See if there's tissue pulling, see if there's any flexibility there that you need to overcome. And then you're going to start doing some kind of measurements. It doesn't have to be perfect. It just has to be observed. You're going to think to yourself, okay, the blade of this tongue is over 16 millimeters. You can eyeball that pretty good. Then you're going to ask your patients to open their mouth as wide as comfortable. You can all do it right now. And then you're going to ask them to put the tip of their tongue behind their upper front teeth. And you're going to note how much closer these incisal edges went. If they closed more than 50%, that's a tongue tie. Then you're going to ask them to do a lingual palatal suction. The lingual palatal suction does require some coaching. So that is the entire licking part of the tongue up against the roof of the mouth. So imagine you're going to do a click. The tip of the tongue should be up near the front teeth. You should be getting a clucking sound, not a kissing sound. So you want them to click, but hold the tongue up against the roof of their mouth. You should have at least 30% of that wide open distance remaining in this posture. If it's not, then it starts to indicate some kind of a restriction in the posterior part of the tongue. And then you're going to look for intra and extraoral compensations. In this picture here, I highlighted the ventral funnel. Some patients have their whole floor of the mouth lifting to accommodate this suction. You're going to see a lot of pull in the neck. You're going to see the mentalis all of a sudden get activated. You're going to get a headache. You're going to have a patient complain about neck pain all of a sudden when they're doing that little suction. And then you're going to look for actual tension, whether it's absent or present, in the neck and across the shoulders in the back. So all these 5 things are what you're going to look at so that you can determine whether or not it's likely that they have a tongue tie. Once you get really schooled on it, and once you really look at it a lot, or if the doctor you're working for is doing tongue tie releases, the functional frenuloplasty, then you're going to get really super good at it. And then you can do stuff about it. But for your one and done kind of thing, you saw a webinar, this is who you would send then for myofunctional assessment. So that's how this whole thing kind of is the easiest way to do. Myofunctional therapy, to become a myofunctional therapist, is very, very long. And every time you think you got it, you don't. And then there's another question or another question. And people are spending $10,000 and $15,000 in classes, and then they're never even seeing a patient, which is why we started to do the mentoring at Primal Air. So if that's you, then give us a call, and then we'll see what we can do about helping you launch your myofunctional career, myofunctional therapy career, because it's really hard to get going if you've never seen a patient or you've never worked with patients. So this is the mobility scale that Dr. Zaghi did with a couple hundred patients. And so you measure the distance between the incisal edges. And in this case, it's 41 millimeters. And then you ask them to do this posture with the tip of the tongue behind the upper incisors. So the tongue is not to be touching the teeth. It should be just smidgen behind. And in this case, you see it's 22 millimeters. And then you do a third measurement with the tongue in that suction posture. So what we do at Primal Air now is we do this posture first, because by the time they get very confused, people get very confused as you're doing these measurements. So we start with the hardest one and then we work towards the easiest one. But the measurement is still the same. It's still 20 millimeters. And if you do decide to take photos, make sure you can see the frenum in the picture. And then you start with some fourth grade arithmetic. You take the measurement of the 22 millimeters with the tongue tip behind the anterior teeth, and you divide by the wide open measurement. And in this case, it's a grade 2 with 53% remaining, but there are compensations for this person. And then you do that suction and you do the same thing. You take the measurement for the suction and divide it by the mouth wide open, and then you get 48%, and that is a grade 2 because of the compensations that go along with it. So this is also from the paper. This is how we measure. This is the tip, the tongue to the incisive papilla. Now these patients do not reach all the way up there. It's easier when they do reach there and then measure the distance between the incisal edges of the teeth. And then this would be the suction. So these are a couple of our patients. Now we had a bunch of people join in after we started. So I wanted to let you know that I'm going to shoot for ending at 8 o'clock. But it's more likely we're going to go to 8:10 or 8:15 Central Time. So it's going to be a little bit longer. This person here, is one of our patients. She was a real high functioning person. She was a runner and she was super active. She was 40 middle years old. She was, having all of these weird symptoms. And mostly she was worried about her anxiety and she wanted to improve her performance. So she did this maneuver here, and I'm not showing all the pictures of everybody, but you can see the blanching. And this is how close she had to get in order to reach the tip of her tongue to her upper lip. So try that right now for yourself. Open your mouth and then put the tip of the tongue to your upper lip. Do you have to pull your lip down? Do you have to close your mouth in order to get there? How is the blanching for you? This was after the release. Zero anxiety. Her performance improved quite a bit for her running, and it was running for sure. She was like running, not just jogging, running. And she could talk with her friend while she was doing almost double time. And then she goes, since my tongue tie release, my pelvic issues resolved. And I said, what? She goes, yeah, I've been working on these pelvic problems for over a year. And I did this and I did that. And she listed all this stuff. And she goes, since that tongue tie release, my pelvic issues have resolved completely. And that goes back to that fascia that I was talking about. This lady here, this is the tongue to incisive papilla measurement, braces 3 times. 3 years in her 40s, 5 years in her 50s, and 3 years again in her 60s. This is 62 years old. She was angry that nobody ever talked to her about her tongue tie, and that the reason that her relapse were happening is because her tongue was not engaged appropriately, and it was jacking up her teeth. And obviously she cares about that, right? So did you count that up? That's 11 years in braces. Her suction improved a lot. She still had in this picture a ventral funnel. This was still healing. And then she goes, you know, since my since my tongue tie release, my constipation has disappeared. And I said, what are you talking about? She goes, I've been constipated my entire life. And as soon as that tongue tie was released, I have not been constipated 1 minute since that time. And I thought, what is happening? What is happening here? How are people living with constipation their entire life, and that somebody could have released that tongue tie when they were a tiny baby and resolved that problem, and she could have dealt with other problems instead? So it's bizarre. It's really, really bizarre. All the effects that are being discovered from releasing this tongue tie. Those kids could eat solid food, you know, whatever. They're fussy eaters. They only eat cheesy noodles. You know, you don't even think about that in the full context of the whole world. This one wants to be an interpreter. Obviously, she has a tongue tie just looking at her teeth. This is all she could do. So her teeth are open maybe 4 millimeters here. She could not do that twirling R, that trilling R. So she came here. The doctor, orthodontist, sent her over here to assess the tongue tie. So what doctors are saying to their patients is that they're sending them to a tongue specialist. So that's how we're referred to by some of our referring doctors. So this was shortly, she wasn't finished here, but this was almost finished. The tongue tie was released. Not only did she have a tongue tie release, she had a physical therapist in the treatment room during the release to manage the unraveling fascia. This doctor will not work without some kind of a body worker involved before, like not a week before, the day of the functional frenuloplasty, and either later that day or the day after. Those appointments all have to be lined up, and she in this case has to work with a myofunctional therapist before any treatment is even considered. This person here was referred to me by a practice in Colorado, and they were mostly interested in solving a periodontal problem. And I was like, okay. So he was very dysfunctional in his tongue movement. He was oral breathing quite a bit, lives in the mountains of Wyoming, I believe. And he's a holistic practitioner. He's naturopath. So the year-long protocol led to improved breathing, lips that were closed. Joy Moeller, who's the main instructor at the AOMT, which is where I went, says that when you close your lips, you starve the bacteria of oxygen. And I don't know exactly how true that is, but it's close enough for the kind of conversation that we're having with most of our patients. So at probably about about right in the middle of the year-long therapy protocol that we were using, he already had no readings over 4 millimeters. He did not want to have his tongue tie released. You can see it's right here, and it's interfering with his suction. But he didn't want to have any surgery. He didn't want to have a procedure, but his suction improved by 4 millimeters over that time. And he felt a lot better. There were still a couple of things that he wanted to mess with, but they weren't really attached to the oral muscles. Let's see, this patient wanted to stop his dental problems and straighten his teeth. And the suction improved by 6 millimeters. And he's very much more confident that his braces and his orthodontic treatment is going to work. This is a patient I just released from care this week. Yes, Monday was our last appointment. A lot of headaches, snoring so bad that his wife was talking about sleeping out on the couch. A lot of symptomology around the headaches and GI problems. You can see the little heart shape right here. He had not had a tongue tie release previously that he knows about, or his mother said, but look how short that is. His blade is really long, right? You can guesstimate that to be over 16 millimeters. I should have an after picture on here by now. So we started therapy, and after the first week, his headaches had stopped just from doing the exercises. This was his beginning suction. So obviously this is not how he ended up. It's so much better. I wish I would have paid more attention to that. I could have put the new picture in here. His tongue is flat. It's flat up here. He's got a really long frenum. The attachment, the floor of the mouth attachment is on the floor of the mouth. His GI symptoms have stopped. He's had one bad enough headache let's see, I started him in June, and then we figured, so June, July, August, September, October, 4 or 5 months. He's only had one headache where he had to take a pill. All of the niggling headaches have all but disappeared. His wife has commented about his improved chewing. His GI problems have stopped messing him up. This is what happens when you have a tongue tie like this. You do one of two things with chewing. You either chew forever, or you just chew until the pieces are just barely big enough to swallow, just like you're swallowing a supplement. So you just go bite, bite, chew, chew, and you just slam it back there and just hope for the best and wait for the muscles to do it. But you know, those muscles are not supposed to be doing that, and they will stop working. They'll just stop working. All of his neck tension is gone. This is one of our therapists in New York, and you can see her Mallampati score in 2019 was a 4. It took her 2 years of just working her tongue and working the pressing of the tongue and doing myofunctional exercises to get that thing to open wide up. This is our little 5-year-old patient. Look at that. He could not do a suction at the beginning. I had to do and wait for him to click. And then I was lucky enough to get a picture. This was, boy, these pictures got jacked up. This is before. You can see that the tip of his tongue is folded over. His speech therapist, who's been working with him for 3 years, you still couldn't understand a word. She said there's no tongue tie because there's no heart shape. You couldn't understand a single word. And here it is 10 days after the release. He's got complete control. He was finished probably in March of this year. He could speak well. and his tongue was completely healed, and everybody was so much happier. This is a lady who decided not to do a tongue tie release. I didn't even know what I was looking at first. Remember I told you how the floor of the mouth lifts? Look at that. It's up over the occlusal surfaces of her lower teeth. Just after a few weeks, you can really see where that frenum is. You can imagine, had she been on a track to do a tongue tie release, you couldn't do it here. It would be a horrible bloodbath. Look at how close those veins are. This is the tongue that's ready to have a release. This is another case. His arch was so narrow, it took 2.5, 3 months for us to get this suction down. You can see the dorsum of the tongue. I talked about a divot in the tongue or a dimple. There it is. Look at his chin. Look at his head posture. This was the day we started therapy. This was the day of his release. So what do you say for your patients? You can talk about a new appreciation for a function of the tongue. We never appreciated the function of the tongue in infancy. I know I learned about that the tongue pressed up against the palate, that's what stretched out the suture, and then the cheeks and the lips were the opposing muscles so that they didn't go haywire out this way. Dentistry has had a low bar for tongue tie that no longer fits the truth. You know what I'm tired of saying? We now know. So I tried to jazz it up a little bit because everybody's tired of hearing we now know. And they're also tired of talking about floss and fluoride when they continuously get decay and they have sleep apnea. We're going to recommend that you see a tongue specialist. Seeing a myofunctional therapist before sending to the oral surgeon or whoever's going to be doing the tongue tie release, if that's what's indicated, is so much better for the patient. It's so much better for your practice, and it's so much better to communicate with the release doctor. Looks like your tongue restriction is accumulating to problems like your jaw joint, caries problems, anxiety, ortho relapse, bedwetting, whatever it is you saw in their health history. That's what you're going to tie that to. Because you looked in their mouth and you didn't say, that's weird, in your head, and then just kept right on going. You said, that's weird, and then talked to your patient about their fat uvula that's been vibrated all night long and it's big and beefy. This is our referral sheet. We can certainly send them to you or just find a local therapist. I'm not here to make sure that everybody sees, Primal Air people. Not that I don't want you to send them over here, but they need a myofunctional therapist. Send them over. Tell us what it is that you want from us so that when we call your patient to say, Dr. So-and-so or hygienist Heidi Hygienist said, you have these problems and these are what we're going to do to help solve those problems. That's the conversation that we would like to have. Now, the doctors are telling me it takes about three appointments to kind of get to where the patient understands well enough. So that should be kind of part of your think tank as well. And today we did a lunch and learn, and I was like, well, maybe we should be doing a lunch and learn every quarter or so that people don't lose momentum. I worked with a lot of companies in the past, and a lot of the companies were like, why are offices so gung-ho about this product? And then they get a lot of no's, like oral cancer screening with the oral CDX brush, and then they would get all these negative results. Well, isn't that a good result? You lose some momentum. So having frequent learn over lunches or something like that can be really helpful. So that's what we were talking about today. So it's a little bit after 8. It's a little bit sooner than I thought I was going to end. So that's all good. And I'd be so anxious to be able to answer any questions from you right now so that you can also do something tomorrow morning with your patients that you're going to see. So go ahead and unmute yourself. Or if you feel like typing, you can put it into the chat. I want to remind you that since this was free and I have no sponsorship here, there are no CEs for this course. I hear somebody's microphone open. Roberta, what you got?
That was amazing.
Oh,
I have a lot of, that's weird to go back to when I looked at my patients in their mouths. So it's an eye opener. I appreciate all the valuable information you gave.
thank you very much.
I don't know where I'm going with it, but I know I have a lot of my fellow hygienists on who I'm sure would love to say something. We have a very big group that came on.
Oh, super.
So thank you.
You're super welcome. And you know, this is, like I said, it's a little 1 hour and 20-minute kind of a presentation. This does take some time to develop in a practice to get to where you want to move to the next thing, because everybody has to kind of be at least sort of on the same wavelength and on the same page.
Right.
So Christy, when I see high floor of the mouth, should I think tongue tie? Are there other factors to look for? That would be the first thing. Just imagine that this is a tongue tie. If you see the floor of the mouth lifting, there's really no other reason for that to be happening. This is a compensation for a dysfunction of the tongue.
Hi, Shirley.
Yes.
Oh, sorry.
Go ahead.
I saw that you were incoming. I'm Ruby. I'm from one of the New York offices. I was wondering about average treatment times. I know I had gotten my niece in, and it definitely has improved some of her problems. She's 7 going on 8 now, and she's been in therapy for probably 2 years now. What would you say is your average treatment protocol time? I know that I probably initially noticed her issues around 3. I probably told her parents around 3.5, 4 that I was noticing her bite opening. But
So when
I
you
know
say therapy,
it's
what are
ongoing.
you talking about? Are you talking about
So
speech therapy?
no, I told them to send her to Mayo. I had fallen down a Mayo rabbit hole probably like 7, 8 years ago for
Yeah.
myself. And so when I noticed her, I'm like, oh no, because my sister had the surgery for an open bite at 19, which she regrets. And
Yeah.
I'm like, you didn't really have a choice at that point in time. We're talking over 20 years ago.
Sure.
She had it done. And for myself, I've been treated twice already with braces. And so that second time I was like, what am I doing wrong?
Yeah.
And I somehow got down the rabbit hole of like that and distraction osteogenesis and all of those things. So when my niece popped up, I was so curious, like, okay, how do we fix this so that it doesn't restructure her face? And so I sent her to Mayo. They just did the tongue release about a month ago, which was really fun to see. And I think she's gotten fitted for a palate expander this week, but I'm wondering for a case like this or for your average adult cases, what is the treatment time?
There's no way to know. It all really depends on the patient themselves. So this is 2 years. I've not had a patient for 2 years. We usually try to finish everything up in a year. And at 7 years of age, that's a long time. It's a really long time. And at 7, I would have started with some kind of I call it a gadget because there's just so many and there's so many different names. There's the Healthy Start, there's the Mayo Research, there's the Mayo Munchie.
She had that.
There's another gadget. So I would have been working, or froggy mouth is another one. So I,
And she did mouth taping as well.
yeah. So, I don't know. I can't, it's weird that
Okay.
they took 2 years to release her tongue.
I think that she had found someone who was kind of far from us, who was a speech therapist who did this, who also specialized in feeding therapy,
Oh,
because my niece would eat painfully slow.
yeah.
Like where you're like, all right, forget it. Just don't eat. It's taking so long. And I think somewhere during the pandemic, they were having issues with that provider, and they switched her to someone this year, I want to say, who started with the Mayo Munchie, who was doing the mouth taping. And I think they were like, all right, get the tongue release now. So I don't know if maybe she just wasn't making progress with the initial therapist.
Could be. I don't know. It's been my painful experience that patients who see a speech person often, it's just like a hygienist. When you know something, everything is that thing. So they
Mm-hmm.
start with speech and they start with all this other stuff. And for me, I'm like, oh my gosh, this is obviously a tongue tie. So
Yes.
it's just so
And
hard to know.
yeah,
Especially without seeing a history, or, I'm just
yeah.
shooting in
I'm
the
just
dark.
curious
I can
for,
tell you,
yeah.
but not seeing anything, that we would have finished her in 2 months. No, I'm kidding. There's no way to
Well,
know.
I mean, I'm just curious what your average case time is. Like for ourselves, if
It
we do this,
completely depends. It so depends. On a 7-year-old, we might just do 6 sessions just to lead up to a tongue tie release, and then to recover, and then work with the other stuff later. Because the tongue tie release can all of a sudden solve a lot of problems almost on
yeah.
its own at that age. So there's that. So there's just no way. I'm so sorry, Ruby. I just don't have a good answer for you without
Well,
any.
yeah, I mean, not even just for her case. I'm curious for
Yeah.
myself if I was to do it and
If you
take on
were a grown
cases.
up and you're already a grown up and you have a tongue tie that needs to be released, and you're like that high performance lady that I was telling you about, we finished her in 10 sessions
Wow.
because everything worked for her. She understood the body, she understood what I was talking about, she understood why, she could figure out answers for herself, and she was just done. And I have another lady that I think is going to take a year for sure, because she can't, a lot of questions, slow moving. I have a girl right now who had a I don't even know what she has. She's got something, and it took her 3 minutes to pull a string up into her mouth, where most people it's like
Mm.
20 or 30 seconds. I'm like, all right, well, this isn't going to go very fast. So there's just no
Mm.
way, without an assessment. So Brenda asked if I could come to her office and do a lunch and learn. I would love to. It's super helpful when the whole team is right on board with that. Even the front office people, which is what we did today. The front office people were there. And then when I got home, when I got back to the office afterwards, we already had a call from a patient who had been seen there for cleaning after lunch. So that was pretty amazing. So we'll see about that. If we're too far away to do an in-person kind of a learn over lunch, we will definitely do one virtual version. And then I think that someone who suffered from a stroke can use OMT when they have speech impairment. What do you think, Shirley? Yes, of course, Hudson Hector. That's one of the kinds of people that we see for recovery from stroke. I've also had Parkinson's patients, and I'm struggling right now with a MS patient. She's a trick. She's a trick, and she's having swallowing issues now, where she's choking on her saliva, and that's exactly what happened with this Parkinson's patient. I just called her out of the blue. She's a friend that I've known for a really long time, and I said, let's do some myofunctional therapy. Let's see how that would work for you. And she's like, okay, all right, let's do it. And so I think we started in like June or July in the summer. And at Thanksgiving time, it was like right after Thanksgiving, she goes, "You know what happened, Shirley?" And I said, "No." I was eating a fruit salad and the grapes had been cut in half and one flew down my throat. And you know what happened? She said, "Nothing. My throat closed off. It squeezed the grape back into my mouth. Nobody knew." And I said, "Oh my gosh, that sounds kind of scary, but that's what's supposed to happen." She goes, "If this would have happened last year or before we did any therapy, it would have been a nightmare. I would have been choking and coughing. I might have even thrown up because my muscles didn't know what to do anymore." So all of those things are really important features. It's not something you run into with your patient base constantly all the time, but certainly those kind of patients who, you know, their saliva goes down the wrong pipe and they cough and they turn all red in the face, those would be definitely patients that would benefit from myofunctional therapy. So, can a certified OMT practice as a sole provider? Yes, even without certification. Right now, it's still the wild, wild west. You need to take the classes. You can only take the classes if you are a licensed professional, licensed to touch people. So there's that. But there's nobody overseeing myofunctional therapy. And there's a lot of myofunctional new graduates from a class, and they're calling their board and asking permission. And the board's like, what are you talking about? And really all that does is stir up a pot. So I'm practicing individually. I am practicing under my dental hygiene license, but I am not practicing as a dental hygienist. I have no mouth mirrors. I have one box of gloves. I have no dental instruments in here whatsoever. I am not doing that. It's very much as though you were to open a toothbrush store and with your knowledge giving people advice on the toothbrushes. You're not really practicing dental hygiene. And so you're kind of, well, you're a little bit on the Wild West. So know your myofunctional therapist. So,
Sure.
yes,
Shirley,
go ahead,
I was
Angela.
I was about to say that one of the easiest red flags to notice before you even look into someone's mouth is a resting open mouth posture. So like when they're resting, if their mouth is open and they don't have a proper lip seal and they're breathing through their mouth, that's like a red flag. Why are they doing that?
Yep, that's exactly right. There's a lot of things you can see right from a patient. You can get a lot of information from their health history and looking at their x-rays before they even walk in, you know. Especially it's a little bit tricky with your existing patients because they are used to a certain thing to happen during this appointment. And when you go, "Wow, your uvula is really big," their eyebrows are up to their hairline and they're like, "What are you talking about?" And now you can have a different conversation. But you can't have somebody walk into your treatment room and sit down and you've seen them for the last 6 years and go, "You know, your mouth is open." You know, you need to kind of dance around a little bit and I don't know. Depends on who you are, I guess. Some people can be nice and dainty and others are more like a hammer. That would be me. But it's a really good point. There's so many things, Angela. You can't do it all in even an hour and a half. So this was the first in a 3-part program I did for the Wisconsin Dental Hygienists Association. And I'm going to be doing the next third coming up in a couple of more weeks on what did I call it? Hold on, let me see. It was about epigenetics. I had a really catchy title. It was so catchy I can't remember it. Evolution, Epigenetics, and the Tinkering of Humans. That's the name of it, and that's going to be another 2-3 weeks. So stand by for that. And I'm so glad that you were able to join me for this whole little hour and 20 minutes. Have a great rest of your night. And if you have any questions, feel free to email me. I'm very, very accessible. Have a good night, everybody.
Thank you, Shirley.
Bye.